Hello, I'm student clinician Tyrone Bird, and today I'm going to demonstrate some shoulder, clavicle, and AC projections. So we're going to start out with shoulder. Now shoulder, there's 6 projections that we're going to show. 3 of them are for chronic or non-traumatic patients. The other 3 are going to be for acute pain or traumatic patients. So starting off with the chronic non-traumatic projections, cassette is going to be 10 by 12. You can use a 12 by 10 cassette, but mainly 10 by 12. Crosswise. The anatomy demonstrated will include lateral 2/3 of the clavicle, glenohumeral joint, upper scapula, as well as proximal humerus. So we're going to start out with the shoulder external, or the AP shoulder external rotation projection. So we're going to have the patient erect, standing up. Their back is going to be against the bucky, so we're going to pretend there's a bucky behind me. We're going to have the patient externally rotate their arm. That's going to mean their hand is going to be kind of in a supine position, palm facing out. What we'd like to do is also insert a angled sponge here, soft sponge, to immobilize the extremity. We're going to use a 40 SID. The central ray is going to be perpendicular to the coracoid process through the center of the film. And again, anatomy demonstrated will include lateral 2/3 of the clavicle, humerus, proximal humerus, glenohumeral joint, as well as the upper scapula. But we're also going to look at the AP humerus, AP view of the humerus. We're going to look at an oblique view of the glenoid fossa. There's going to be superimposition of the greater and lesser tuberosity. It's going to be separated by the bicipital groove. One thing we want to keep in mind with this projection is we wouldn't do this, or we wouldn't have the patient rotate the arm if there was any trauma involved. So once we get the patient in position, we're going to have the patient look away. We're going to shield the patient. We're going to ask them to suspend breathing and don't move. Next view is going to be an AP shoulder with internal rotation. So kind of same setup, bucky's behind me or bucky's behind the patient. You're going to have the patient place their back against the bucky. Going to, of course, center the film. We're going to have the patient internally rotate the arm, placing the back of the hand against the thigh. Again, we're looking at 40 SID. Central ray is going to be perpendicular to the coracoid process, centered to the film. Anatomy demonstrated, again, includes lateral 2/3 of the clavicle, proximal humerus, upper scapula, as well as the glenohumeral joint. In addition, we're going to be looking at greater tuberosity on the lateral side, as well as the lesser tuberosity near the glenoid fossa. Again, we're going to shield the patient. We're going to ask the patient to look away. We're going to ask them to suspend breathing and don't move. Again, keep in mind that if there's any trauma to the arm, you would not have them rotate. Next is going to be our AP shoulder baby arm projection or abduction projection. So again, patient will place their back against the bucky. We're going to have them do kind of the oath sign. So arm is going to be abducted. We're going to have them flex the elbow 90 degrees. Again, 40 SID. Central ray is going to be perpendicular to the coracoid process. In this particular view, in addition to the lateral 2/3 of the clavicle, proximal humerus, glenohumeral joint, and upper scapula, you're going to be looking at the shoulder joint and the AC joint. Again, we're going to shield the patient, ask the patient to look away. We're going to ask them to suspend breathing and don't move. So those are our 3 views for chronic pain, non-traumatic patients. So now we have 3 views for an acute pain or patient with some type of trauma. So the first one is going to be again, we're going to be using cassette that's 10 by 12. In these particular views, you want to include the entire clavicle, as well as the proximal humerus and the entire scapula if possible. So the first view is going to be AP shoulder as presented. So in this particular case, a patient will have trauma and they may come in with their arm dangling. If they do, you're going to think of a fracture. If they come in this motion with a hand across the chest or stomach, elbow bent, you're thinking dislocation. So if we're doing this particular projection, again, bucky's behind the patient, patient's back against the bucky. If they present with the arm dangling, you're just going to have them continue to leave the arm in the position it's in, have them place the hand against the thigh. Again, 40 SID in this case, central raise perpendicular to the coracoid process, and we're looking for a fracture. If the patient presents with this particular motion, we're going to have them place their back against the bucky, leave it in this position here. We're thinking, again, of shoulder dislocation, 40 SID. The patient, we're going to have the central ray perpendicular to the coracoid process. And again, we're looking at the entire scapula, entire clavicle, and the proximal humerus. Again, what we want to do is also shield the patient, ask them to look away, suspend breathing, and don't move. Next is going to be a special projection called the Gray-Shaw projection. It's going to have the patient back against the bucky, but in this case, you're going to rotate the patient 30 degrees. So let's say that the left shoulder is the affected shoulder. Bucky's behind, place the back against the bucky, rotate 30 degrees. The affected shoulder is against the bucky. Again, 40 SID. The central raise perpendicular to the coracoid process. And in this case, we're looking at the lateral glenohumeral joint for this particular projection. We're going to ask the patient to suspend breathing. We're going to shield them, ask them to look away and not move. Next projection is going to be the scapula Y projection. So in this case, the patient is actually going to turn and face the bucky. So I'm going to turn around, face the bucky. There's 60 degrees of rotation in this particular view. So body rotation. So have the patient facing the bucky. We're going to have the affected shoulder. Again, we're going to use my left shoulder as the affected shoulder. Affected shoulder is going to touch the bucky. There's going to be 60 degrees body rotation. You're going to ask the patient to take their hand, lay it across their stomach, bend the elbow. The SID is 40. The central ray is going to be perpendicular to the scapular humeral joint in this particular projection. So I'm going to face you. Looks like we're going to simulate that the bucky's in front. Affected shoulder is going to be against the bucky, 60 degrees body rotation, hand across the stomach. Again, 40 SID with the central ray perpendicular to the scapular humeral joint. Again, what we would have the patient do is suspend breathing, don't move, and shield the patient for protection from radiation. So those are our shoulder projections. Next, we're going to look at a couple clavicle projections. There's two in particular. It's going to be the AP-PA clavicle. Again, patient is erect, bucky's behind. Have the patient stand against the bucky, 40 SID. Now, the central ray, once you center the patient, the central ray is going to be mid-clavicle. And what we're looking at here is the entire clavicle being captured. Again, shield the patient, ask them to look away, suspend breathing, and don't move. Next is the PA clavicle projection. And this is the same thing. Patient is up against the bucky. We're looking at 40 SID, central raise, midpoint to the clavicle. In this particular view though, we're going to include a 10 to 15 degrees cephalad tube tilt or tube angle in order to capture not only the clavicle, but the entire scapula as well. Again, shield the patient, have them look away, ask them to don't breathe, don't move in order to get proper projection. Lastly, we're going to do AC joints. Now with the AC joints, there are two particular projections. You're either going to do a unilateral projection or a bilateral projection. So in this case, with the AC joint, you're using 14 by 17 cassette crosswise if they're a smaller person. If they're a larger individual, you'll end up using two 8 by 10s or two 10 by 12s end to end in order to capture. So let's say we're doing the unilateral projection of the AC joint. We'll have the patient stand against the Bucky's behind. Now we're going to center the X-ray about 1.5 inches above the jugular notch. So what we're looking at is a central ray that's kind of perpendicular to the body. It's going to be midpoint between the two AC joints. We're going to use 72 SID, we're going to use 40 SID for the unilateral projection. And again, we're going to do 4 particular views or 4 particular exposures with this one. So you're going to do 2 for each AC joint. One is going to be with no weight. The other is going to be with 10 to 20 pound weight or sandbag, so that you can view any type of separation or anything like that in the AC joint. So again, 40 SID, 4 particular views, or 4 particular exposures, 2 with weight, 2 with no weights. Now, if we're doing a bilateral projection, again, 14 by 17 cassette crosswise, or 2 8 by 10s or 2 10 by 12s. Again, patient's back is against the Bucky. Central ray perpendicular to the body, about 1.5 inches above the jugular notch, midpoint between the AC joints. And this particular view, we're going to capture both AC joints in there, so we don't need 4 views for this one. SID for the bilateral is going to be 72 instead of 40 in this particular case. Now again, instructing the patient to don't breathe, don't move, and provide shielding for projection. So those are our views for the day. Again, shoulder, clavicle, and AC joints. Thanks for watching.